Give me a second. Okay, now it should be recording. It's recording now.
Thank you. Dr. Soares, we also just start in like 2 minutes.
Sounds good.
I'll start now. Good morning, everyone. This is Devraj. I'm one of the chief resident in child neurology at SUNY Downstate Medical Center. Me and my colleague, co-chief resident, Neurology, we will welcome all of you for today's grand round. Also extend my welcome to the people from LI, Long Island Jewish Hospital, Cornell, Rutgers, Maimonides Medical Center, and Kings County Hospital. Today's grand round is very special. I was really looking forward to this one, and this is one of our neuroradiology grand round, specifically pediatric neuroradiology grand round. And the speaker is all the way from Vermont, Dr. Soares. Dr. Soares is an academic pediatric and adult neuroradiologist. He completed his medical school at the Federal University of Rio de Janeiro, followed by residence in radiology at the Federal University of Sao Paulo, both in Brazil. He moved to United States in 2008 and underwent for clinical fellowships in neuroradiology, pediatric radiology, and pediatric neuroradiology at UCSF. After working at Emory University and Johns Hopkins, he currently serves as a director of the neuroradiology and vice chair of imaging research at University of Vermont. Dr. Soares has published about 70 articles and given several national and international lectures in the field of pediatric neurology. Actually, that's how I approached him. He was giving the international pediatric neuroradiology metabolic round, and that's how I was like, wow, that's so amazing. And has received teaching awards from UCSF and from Johns Hopkins. He's particularly interested in neonatal brain imaging, brain malformations, epilepsy, neurometabolic disorders. His current research efforts focus on disrupted cerebellar activation pattern on functional MRI in children with born prematurely. So here's our welcome once again, Dr. Soares, and take over.
Thank you very much, Dev, and to the kind introduction and the kind invitation from SUNY Downstate, Brooklyn. Also, very pleased that other programs in the New York area are joining us. I understand the audience is mostly comprised of pediatric neurology and adult neurology trainees and faculty. So the talk will be geared towards all of you. So let's get started. Our goal today is to establish a framework for a pattern approach on MRI to pediatric neurometabolic disorders. No disclosures. And this is what we're going to do today. First, we're going to recognize what is normal myelin maturation on MRI and distinguish a couple of terms and get the terminology and the pattern approach correct for hypomyelinating and hypomyelinating disorders and distinguish that from demyelinating leukodystrophies. First, we'll just establish what these terms mean and then look at some images. We'll identify some helpful clinical imaging pattern that suggest the clinical diagnosis, and also a couple of clinical findings that really add specificity to what we're looking on MRI. And of course, as a radiologist, I will illustrate with pictures some common and more recognizable disorders. I always start this talk by saying, okay, now we're going to discuss all the inherited white matter disease by organelles involved: mitochondrial, lysosomal, peroxisomal, Golgi complex. That is really a good way of emptying a room, or to start listening people dropping the Zoom call, because of course, this is not very helpful unless you're a molecular biologist. And it's not useful for the clinician who's seeing a patient with a suspected leukodystrophy or inherited white matter disease. I'm using that interchangeably, and not useful for the radiologist who's looking at an MRI scan and trying to collect some clinical information to put things in context and provide the best clinical radiological diagnosis. So we are not going to go there, even though there are several recent and even more recent proposed mechanistic classifications of leukodystrophy, which are fascinating to study. And they divide things into myelin disorders, and notice that abnormal formation or breakdown of myelin is here, and also disorders related to different cell populations in the CNS. But as this is a radiology talk, we're going to start by recognizing what is normal, and it requires some expertise in study, because the normal adult brain doesn't change much other than brain atrophy with aging. The normal pediatric brain undergoes a lot of change in the first, in utero, and then in the first 2 years of life. So normal myelination occurs in a very predictable fashion, like a blooming flower, from posterior to anterior, from central, the more primitive brain structures, brainstem and so on, to peripheral. And it's also important to know that changes on T1 weighted images precede the changes on T2 weighted images. Again, T1 before T2, easy to remember. I'll give you an example here. Look at the newborn brain, it's watery. So the white matter has water signal. Water is dark on T1, so it's hypointense, more hypointense than the cortex. But as the myelin forms, myelin formation, and myelin is essentially phospholipids, cholesterol, and protein. So it has some signal intensity that increase on T1 shortening, as we call, like fat, even though it's not just fat, it's fat and protein. And here at 2 years of age, essentially you have a complete myelination pattern. Actually on T1, by 1 year of age is essentially complete, where the white matter is brighter than the cortex. On T2, we have the opposite. We have a watery brain where the white matter is brighter than the cortex, just like fluid on T2. And then as the myelin sheath tightens and decrease the extracellular water content in the white matter is not so watery and it becomes dark, okay? But even in the newborn, you already have some myelination, as you can see here, the posterior limb of the internal capsule, a little dash here, the ventrolateral thalamus. So this is motor and this is sensory. And there's a concept here, if it fires, it wires. These are the most active regions in a newborn, as opposed to, for example, the anterior frontal lobe cortex in white matter. So the areas of sensory, motor, and brainstem tracts will myelinate before the rest of the brain, certainly before the subcortical white matter association fibers. Okay, so this is essentially a screenplay that features T1 and T2 weighted images, and the functional pathways used early in life, sensory, motor tract, vision, brainstem nuclei, that will myelinate earlier, because what are babies doing? Looking at mom, eating, screaming, eating, checking, and that's what will myelinate first, okay? If it fires, it wires. Basic stuff first. I mentioned that to you already. Here is a representation of that process. Brainstem, central fibers, motor fibers, sensory fibers, and lastly, subcortical fibers. Now let's look at MR images. In a newborn at term, and we should always know if you're looking at the brain of a premature or of a term newborn. If you are experienced, you can just look at the sulcation and kind of guess the gestational age. And here is a term newborn where you see the posterior limb of the internal capsule. By 4 months, you have myelination in the splenium. And this is 4 months of corrected gestational age. No need for correction if you're dealing with a term newborn. But if you're dealing, let's say, with a 2-month, a premature baby that was born 2 months earlier, you have to correct your gestational age in the first year of life to interpret the MR. So remember posterior before anterior. So 4 months, the splenium myelinates and is bright on T1. 6 months, the genu of the corpus callosum myelinates and it's bright on T1. At 12 months, essentially complete myelination on T1 weighted images. Looking on T2, the posterior limb is just a little dash at birth, as I showed you. Then at 4 months, it's a thicker, more robust posterior limb. At 6 months, now you have the splenium, which was 4 months on T1. Notice that the genu is not yet dark, so not yet myelinated. Genu myelinates at 8 months. And then I'm showing you an example at 1 year of age, splenium, genu, posterior limb, and also here now the anterior limb. Notice how if you look at the peripheral white matter, it's not yet. You can interrupt with questions, or if you think it's more convenient, you can just write in the chat and we'll have time to discuss at the end of the talk. This is, as far as my PowerPoint skills go, this is really easy to remember because if you look T1, T2, splenium and genu, splenium is posterior. So 4 months bright on T1, 6 months dark on T2, genu 6 and 8. Or if you think on T1 weighted sequences, 4 and 6, 6 and 8. So however you look, this really helps. I have to confess that I'm better at guessing the age of an infant by looking at the MRI than by watching the infant. And I've been put in some embarrassing situations because of that. But imagine, for example, on T1, the entire corpus callosum is bright. On T2, the splenium is dark, but the genu is not yet hypointense. And then you say, oh, this child, if it was born at term, it's probably around 7 months. And most of the times you will be correct or very close to the right age. So that's a good one to memorize of the milestones of myelination. The corpus callosum really serves as a fingerprint. There are a couple of pitfalls in evaluating the white matter in infants and young children. One is to confuse normal with abnormal findings. So a lot of what pediatric neuroradiologists do is to establish if findings are potentially normal or definitely abnormal. And the other one is to establish if findings are congenital and the child was born with it, either inherited or acquired as a disruption, or if it's postnatal. So for example, a malformation versus an acquired injury. And here we have an acquired injury that it usually occurs in prematures, the white matter injury of prematurity that results in periventricular leukomalacia, axial T2 flare images showing normal cortex. But notice how there's paucity of white matter volume where the cortex almost contacts the ependyma. There is periventricular gliosis, which contacts the ependyma, and it's posterior more than anterior, extending to the corona radiata and central semiovalis. So this is classic periventricular leukomalacia, usually premature babies that will develop spastic cerebral palsy, which may be spastic diplegia or spastic quadriplegia, also affecting the upper extremities. This should not be confused with the small areas that have immature white matter and mildly prominent perivascular spaces, and they occur in the periatrial white matter, but do not contact the ependyma. They may also occur in the juxtacortical white matter. These are areas of immature white matter that are normal and may persist up to 20 years of age or so. And you can see here, and on flare as well. So sometimes there's a gray zone where if a child has symptoms suggestive of a leukodystrophy, maybe difficult to distinguish these two, but I would say most of the time, depending on the clinical symptoms and the careful analysis of the images, we can decide if something is normal or abnormal or that it needs follow-up. The good radiologists, just like the good clinicians, should be able to deal with uncertainty and recommend the best course of management. It's not always a binary finding. Moving on to pathologic processes from normal myelination. Now we're going to try to distinguish hypomyelination from demyelination. So let's just deal with the terminology first. Hypomyelination just means that you're not forming enough myelin. And it could be no myelin at all or less than expected, okay? To formally define something as hypomyelination, theoretically, you need 2 MRI scans of the brain, 6 months apart, and the second one, the child has to be older than 1 year of age. But as I'm going to show you, some cases have such striking lack of myelin that you can probably, practically speaking, say this is a hypomyelinating disorder from the get-go, as opposed to mild non-specific delayed myelination, okay? Now, demyelination just means destruction or breakdown of myelin. If you have normally formed myelin and then into your adulthood, you develop multiple sclerosis, that's demyelination, but you're destroying myelin that was normally formed. If you have dysmyelination, which is from an enzymatic genetic defect, you formed abnormal myelin from birth, and you maintain abnormally myelin, then later it starts breaking down, then you have now a demyelinating leukodystrophy. So dysmyelination, I don't use the term because it's confusing, but it just means it's abnormally formed. But for example, X-linked leukodystrophy, the classic cerebral form, you have dysmyelination until one day, because of a trauma or infection, you start breaking down, you trigger the breakdown of myelin, then you develop a demyelinating leukodystrophy. If we look at and understand leukodystrophy as an inherited disorder that predominantly, but not exclusively, affects the white matter, we can only talk about leukoencephalopathy or leukodystrophy if there is abnormal signal on T2. So that is sine qua non. You have to have abnormal signal on T2 to even start thinking about it. Now, in demyelinating disorders, because you have destruction or breakdown of myelin, you have T1 hypointense signal. Similar to the black holes we see in multiple sclerosis, right? Which indicate a more severe degree of injury to the white matter than just the T2 hyperintense lesions. And the black holes, as you all know, they correlate better with the clinical disability scores in multiple sclerosis. Now, in a hypomyelinating disorder, remember the T1 may be somewhat isointense to the cortex, or maybe slightly increased, but not as increased as you would expect. But there shouldn't be breakdown of the white matter because there is no inflammation. So this is one of the most important slides because symmetric findings can be really tricky for radiologists and for clinicians. We're always looking for asymmetry to make our diagnosis. But if neurologists see a 21-month-old boy with spasticity and abnormal ocular movements, they will think, oh, these clinical signs and symptoms are indicating long tract signs, so there's a problem in the white matter. But reader may look at the white matter here and say, well, there's no cavitation, looks absolutely symmetric, but is this a normal scan? The white matter near 2 years of age should have essentially complete myelination, as I showed you. And one of the first structures to myelinate is the posterior limb of the internal capsule. And myelination on T2 is dark because of the tightening of the myelin sheath and decrease of the extracellular water in the white matter. So this is absolute lack of myelin, even in the most primitive structures, such as the posterior limb. And when we look at T1, you have this monotonous isointense pattern indicating that there is no breakdown of myelin, but there's no formation either. At this point or after 1 year of age, the myelin should be brighter than the cortex on T1. So there's no atrophy, I could show you more slides showing there is no restricted diffusion, there is no enhancement, meaning no inflammation. There is just lack of myelin, absolute lack of myelin. The prototypical disorder that caused that, or the prototypical hypomyelinating disorder, where the white matter volume is normal until later in life, you can compare here to the normal term newborn, and again showing the plic, that is called Pelizaeus-Merzbacher disease, okay? And so as I'm showing here, it's quite an easy diagnosis of hypomyelination in this brain if you just know the basics of the myelination process. And it's the proteolipid protein that is affected. There are different types of genetic problems that may cause it. It's usually X-linked recessive, but the severity depends on the type of the mutation. And as I mentioned, the imaging pattern is this characteristic lack of myelination without atrophy until later stages of the disorder. Now that I hope we establish what hypomyelination looks like, we can start looking at other disorders. And here is a big sigh of relief that I have. The first disorder was a mouthful, Pelizaeus-Merzbacher, with an eponym that doesn't really tell you what the disorder is. But later, several groups, including Van der Knap's group in Amsterdam, they have started collecting cases, and according to the clinical and the MRI patterns, and initially on piece of paper, then with very, very basic proprietary software, and they started grouping the cases that look together and doing genetic analysis. And with that, they found a few disorders, including, for example, vanishing white matter disease and megalencephaly with leukoencephalopathy and subcortical cysts, two disorders that in the past have been called Van der Knap disease, but she said herself, please don't use my name because it's not very explanatory of what the disorder is. And because some of these disorders started being recognized initially and grouped the patients by their MRI phenotype, sometimes the name of the disorder is the name of the MRI findings. And of course, I love that because I'm a radiologist. So this is a case courtesy of Professor Andrea Rossi. He's one of the preeminent pediatric neuroradiologists in the world in Genova, Italy. And this child has cognitive deficit, slowly progressive spasticity, okay, so that's long tract signs, but also dystonia and ataxia. And you're like, oh, is there something going on in the basal ganglia, something going on in the cerebellum? We start looking at the images, the axial T2 in a 4-year-old should be completely myelinated, and this looks like a newborn. The white matter is completely brighter than the cortex. So there's no myelin at all. On T1, actually the callosum is a little bright. So there is some myelin, but not enough to show on T2. So there is either hypomyelination or very delayed myelination. On the sagittal midline T1, you will also recognize prominent cerebellar fissures, indicating cerebellar atrophy. Sometimes hypoplasia can look like that. Most commonly it's just a little blob of tissue, but it can look like that. And when we look at the basal ganglia, we had to put an arrow to show that there's profound atrophy of the lentiform nucleus, particularly the putamen, and you can barely recognize it here. So there is hypomyelination with atrophy of the cerebellum and of the basal ganglia. And lucky enough, this is the name that was adopted for this disorder, HABC, hypomyelination with atrophy of the basal ganglia and cerebellum. So even a person who doesn't know much about genetics, such as myself, can make the specific diagnosis looking at the MRIs, and the name of the disorder is auto-explanatory. I'll show you a different one, and in this case, it's somewhat controversial, the part on hypomyelination here. So first thing to notice is this child has some myelination. The callosum is very thin, but slightly bright. On T1, there are areas that are showing that are brighter than the cortex, but there are also areas that look like myelin injury. And that is the controversy here, if this is truly just hypomyelination or if there is breakdown. But mostly the pattern is this monotonous isointense signal and bright signal on T2. Not very bright, but again, 7-year-old, no myelin at all. The white matter is brighter than the cortex. This is the opposite of what we should see. Then we look for ancillary findings. There is no atrophy of the cerebellum, not showing you the basal ganglia very well, but there's no atrophy. But look, this is not the normal shape of the lens. This is a prosthetic lens. So this child has had lens replacement. Why do we do that? For cataract. So this is hypomyelination with congenital cataract. That's the name of the disorder, okay? Again, just by pattern approach, you can get closer to the diagnosis. But this child also had seizures. So we're not done with our evaluation. I can see the leukoencephalopathy, some volume loss. The white matter is abnormal, but why the seizures in a white matter disorder? And looking at the coronal T2, notice the normal right hippocampus and the atrophic and T2 bright left hippocampus consistent with mesial temporal sclerosis. So this is a teaching point of avoiding satisfaction of search. The radiologist or the neurologist that is looking for a finding, they find it and they move on, but the scan still has a couple more surprises to be shown. For example, in stroke imaging, or when you find the first aneurysm, it's always imperative that you look for the second one. Okay, so I hope that in these few slides, we established the basic difference between hypomyelination and demyelination. So now I'm going to show you some findings that suggest inherited disorders, leukodystrophies versus other acquired disorders, some gradients and topography that indicate to you which disease you're dealing with, and I'll show you some vignettes about these disorders, and then findings such as enhancement, infratentorial spinal involvement that help you with narrowing your differential diagnosis. So here's you have the example of symmetry, a child with recurrent ADM, which is myelin oligodendrocyte antibody positive, the antibody that seems to predict a relapsing course of ADM, and has these fluffy white matter lesions, some involvement of the basal ganglia, but it's asymmetric. And in this child with metachromatic leukodystrophy, with this symmetric involvement of the deep white matter and the thyroid pattern that we're going to talk in more detail. Topography. Here we have a child with a big head and has frontal white matter predominance extending to the subinsular white matter, extreme and external capsule. The claustrum is delineated because of that. There's swelling of the basal ganglia, and there's the Garland sign, which will show more detail near the frontal horns of T2 shortening and T1 shortening and enhancement. So this is Alexander disease. Or classic cerebral X-linked adrenoleukodystrophy that starts in the splenium and extends to the white matter. And here, 85% of the cases, that's from Ugo Moser's series in 2005, showing that 85% have this classic pattern, but for reasons that are unknown to me, 15% have a frontal predominance. So topography and gradients can help your diagnosis. So with that, I'll just give you an example that we don't have to memorize all the disorders, but we have to create a map, a catalog of patterns and findings so we can go to Google or the textbook or PubMed and find and narrow our differential. So when you look at the white matter, decide if you're looking at hypomyelination or demyelination. And if you're looking at demyelination, map the periventricular, deep subcortical, and sometimes even juxtacortical white matter involvement that will help you. Then look at the gray matter as well. Is it also involving the cortex and the deep gray nuclei? As I mentioned, leukodystrophies as a broad group doesn't include disorders that may also involve gray matter. And here's a child with ADHD that is now presenting with this slowly progressive visual loss and gait disturbance on T2 flare axial cut, involvement of the splenium and parieto-occipital white matter sparing of the cortex. On T1, you see the hypointensity of the affected areas and these marginal areas of T1 hyperintense signal. This is similar to what you can see in demyelinating plaques. This is breakdown of myelin byproducts and enhancement of the peripheral zones. So these several zones of involvement are very similar to what you see in tumefactive demyelination. It's like a fire in the forest. The involvement starts more centrally and spreads centrifugally. This is classic of X-linked adrenoleukodystrophy. And as you all know, it's a peroxisomal disorder. You test a very long chain fatty acids. And I mentioned how 85% involve the posterior white matter. When we are imaging siblings of kids with adrenoleukodystrophy, we look very carefully at the splenium on T2 and flare because that's where the involvement starts. There are older studies with spectroscopy showing spectroscopy alterations before the onset of conventional MRI changes, and that is used in some reference centers as well. So now a different patient, a 2-year-old girl with progressive strabismus, ataxia, and hyperreflexia. And notice the findings here are deep and periventricular white matter involvement, sparing of the subcortical fibers on T2. This is axial T2, and an inversion recovery image, a true IR image that looks like T1 weighting, but look at this sparing of the subcortical, and then the tigroid pattern, which is the sparing of perivenular areas. That is not entirely pathognomonic, but when it's that prominent, it's quite characteristic with the overall imaging pattern of metachromatic leukodystrophy. So far, we're kind of lucky that some of the most common leukodystrophies, metachromatic, X-link, and there's also Krabbe's disease, which I'm not sure included on this presentation. They are recognizable by MR, and they are some of the most common. I should also say that this pattern approach and the approach initially led by the Van der Knaap group in Amsterdam has, in the last 20 years, markedly increased the rate of diagnosis of leukodystrophies. So a significant percentage, maybe more than half, would be diagnosed as unknown. And now we're much closer to diagnosing the vast majority of these leukodystrophies. I just want to quote you on the numbers. I don't want to be incorrect, but review articles from Van der Knaap's group will give you the percentage. So this is a leukodystrophy, a real sulfatase A deficiency causes this pattern. And I just want to point out that several leukodystrophies, including metachromatic and X-linked, can have also peripheral nervous system demyelination once the disease starts its active myelin breakdown phase. And here you see enhancement of cauda-equina nerve roots, enhancement of the cranial nerve 7/8 complex in the IAC, and enhancement of the trigeminal nerves as well, going into, from the lateral bones going into Meckel's cave. So it's an important ancillary finding that some of the leukodystrophies don't have inflammatory changes at all. There are several important clinical clues. History of prematurity doesn't really correlate with having a neurometabolic disorder, but may lead you to either acquired white matter injury or some other entities. Developmental delay, then the timing of presentation, you know, there's a neonatal, early infantile, late infantile, juvenile, adult presentation of several of these disorders, depending on the severity of the defect and the enzymatic deficiency. The signs of white matter involvement we already mentioned. And then I would mention one that is particularly useful for me and easy to fish out of the medical charts is head circumference, because, for example, a child with abnormal white matter and microcephaly may have congenital CMV infection, while a child with abnormal white matter and a big head, I start narrowing my differential diagnosis into some of these disorders here. I showed you Alexander. I think I'm going to show you in more detail. Canavan disease, megalencephaly with leukoencephalopathy and subcortical cysts, where the subcortical cyst may be in the temporal pulse, somewhat similar to congenital CMV. The difference is that MLC kids have big heads, CMV kids have microcephaly. Vanishing white matter disease, GM2 gangliosidosis, glutaric aciduria type 1. So here's a 14-month-old with macrocephaly and failure to attain milestones. This is a recurrent joke on my part. Every time we see improperly performed study, not properly indicated, for example, here, this child doesn't have anything emergent that would require CT, so should have received an MRI. So we radiologists always say study performed at outside institution, just not to admit that we performed a CT instead of an MR that was more indicated at our institution. But to be honest, I don't remember if this was performed at an outside hospital or not. Most importantly, this child has a big head, frontal white matter hypodensity. We have no idea what it is on CT, but we do the MR. I've shown you this picture before. Notice how there is some T1 hyperintense curvilinear signal anterior to the frontal horn that enhances. This is the Garland sign, which is very characteristic of Alexander disease, as is the frontal white matter involvement, the subinsular white matter involvement, delineating and sparing the claustrum, and the swelling of the basal ganglia. So relatively easy diagnosis of Alexander disease. Fibrinoid leukodystrophy, GFAP, mutation with a very large phenotypical spectrum. This is the typical infantile form I'm showing you. But remember, the adult form of Alexander disease may involve the medulla, and accumulation of metabolites may cause focal swelling of parts of the medulla that they mimic somewhat exophytic medullary gliomas, okay? So if you ever see a case like that, please share with me. It's always fascinating, but the presentation of adult Alexander disease is quite different than the infantile form. Now, this is a different diagnosis where there's also a child with a big head, and if I show you the spectroscopy, this is too easy, but we don't always do spectroscopy. We can talk about spectroscopy after this talk, but if I'm presented just with these images, this child has a big head. Now look at T1, there is myelination in the deep and periventricular white matter, but she's already 2 years old, should be completely myelinated, and the subcortical white matter is dark and is bright on T2. So there is a process here that is affecting first the subcortical white matter. There are very few disorders that cause that. L2 hydroxyglutaric aciduria, which is quite rare and is associated with intracranial tumors, Canavan disease, and then we look, there's swelling around the basal ganglia, particularly swelling of the globus pallidus. So the globus pallidus involvement, the big head, the subcortical white matter should tell you that this is Canavan disease. But if you know that you're imaging this child for a suspected neurometabolic disorder, you do spectroscopy, and here you have at 3 parts per million, that 3.2, choline, creatine, and NAA, which is a marker of neuronal density and viability. So you want your NAA to be higher than these two, but you don't want it to be as high because that is indicating an accumulation of N-acetylaspartate due to an enzymatic deficiency. That is essentially only occurs with Canavan disease, okay? I'm not sure I'm gonna bring you details of spectroscopy, but the pattern that you see is dependent on age. So you have a pattern similar to an adult with choline, creatine, and NAA somewhere around here after 2 years of age, but in the first few months of life, you have high choline from membrane turnover and low NAA, and that pattern kind of inverts and forms a normal Hunter angle over time. But this is an extreme amount of NAA confirming Canavan disease. Okay, this is a different disorder. I'm showing you a somewhat late stage of it. So first thing to notice is the infratentorial white matter, supratentorial white matter are affected on these T2 weighted images. The white matter is so bright that it's almost the same signal intensity as the CSF. This is a late stage case because there's already brain atrophy, which doesn't occur in the early phase of the disease. When you image with FLAIR, that cystic transformation of the white matter becomes evident because free water suppresses on FLAIR. And here it does suppress, and all you see are these residual glial strands and cortex that with the sulci near each other because of the white matter atrophy. There is no enhancement or restricted diffusion to indicate inflammation. So this is a late stage vanishing white matter disease, okay? And here is a different entity. So vanishing white matter disease is one of the disorders that was called van der Knapp's disease. Just try to not call any disorder van der Knapp disease. So here, this child has subcortical cysts in the temporal poles, Like I mentioned, this can occur with congenital CMV, but this child has a big head. We're still talking about the children with macrocephaly. There are also subcortical cysts in the frontal lobes. Notice the diffuse leukoencephalopathy. The white matter is all bright and somewhat swollen at this stage. The cortex is not destroyed, but it's thinned, maybe by mass effect. So this is a very, very interesting entity because yes, it's a leukodystrophy, but there is no breakdown of myelin here. This is a disorder of water and ion homeostasis. Essentially, you're accumulating too much water in the white matter, and at some point, it decompresses into the interstitial or perivascular space that has interstitial fluid, and it pushes on the cortex. So this is just water accumulation. And what is even more fascinating is that there are a few genes with different inheritance patterns, and they have completely different clinical course, as I'm going to show you. It's more precise to classify that as a vacuolating myelinopathy because of these fluid-filled vacuoles in the myelin. Presentation at around age 2 with gradual progression in most cases, but not always. And there's usually the swollen white matter with absent myelination, subcortical cysts, and initially no atrophy. This was described by Van der Knap's group, but at the same time by a neurologist in India that published maybe a couple months later. And Van der Knap's group acknowledged that and said, please don't use my name because I may not have been the first to find out about these cases. And here is with the gene MLC1A, usually you have progressive disorder, and notice this, how swollen this brain is on CT. And then at 15 years of age, atrophy. Notice the atrophy and still the white matter not very myelinated. Now, I don't have a case, but I took from Neurology in 2014 of the other gene that was autosomal dominant, MLC2B, a 10-month-old, looks very similar to the first one I showed you. Cyst starting to form in the anterior temporal lobe, swollen white matter. At 6 years of age, it's a normal brain, and you would never have guessed that this child has MLC. So the disorder of water and ion homeostasis just resolves with this other gene mutation and sometimes leaves no sequela in the brain. I think that's fascinating. So if we build a pattern recognition map, I'll give you one example, not trying to write a textbook. So here is, let's say we found white matter involvement, subcortical predominance. We also found macrocephaly, which I told you, at least for me, it's a very useful clinical finding. Then we just go, okay, which disorders affect the subcortical white matter with macrocephaly? This will be in Barkovich's book. It will be on Google or PubMed. Pardon me. Alexander disease, frontal lobe involvement that may enhance the Garland sign. Canavan disease with also deep gray involvement, particularly the globus pallidus, and increase N-acetyl aspartate on spectroscopy. Vanishing white matter disease, essentially that liquefaction of the white matter without atrophy, and MLC or megalencephalic leukoencephalopathy with subcortical cysts with swollen white matter in the initial phase and the subcortical cysts in the anterior temporal and frontal lobes. So this is how we build our diagnostic map on MRI. So my conclusions for this presentation is we have to recognize the normal myelination milestones. That's one of the most important. So remember, myelination starts on T1 weighted images and then on T2, essentially complete on T1 weighted images at 1 year of age, and essentially complete on T2 weighted images at 2 years of age. Remember that it's posterior to anterior, central to peripheral, and identify the hypomyelination patterns and distinguish from patterns that have white matter injury. That is key, is not just relying on symmetry, but having a very basic understanding, also correcting the gestational age for premature babies in the first year of life. The pattern approach that I showed here, which is not my trademark, but it's just the way to read these cases, is essentially systematically mapping the areas of CNS involvement. It's like having a little paper form brain, say, is this involved? Is this bright or not? Restricted diffusion, yes or no. Enhancement, yes or no. And then once you finish that, It's like a voting form where you put in a machine and it will tell you what the choices are. And then be familiar with clinical clues, which is for radiologists. I would understand that the neurologist would start with the clinical clues and then look at the images, which makes it even more fun. And I gave the example of macrocephaly and also multisystemic involvement, right, if present. And then imaging patterns that would suggest a specific diagnosis. I showed you X-linked adrenal leukodystrophy, metachromatic, and then all these macrocephalic leukodystrophies. So one case as an exercise, and this is a case here from the University of Vermont, where, as you know, Vermont is a small state, aging population, but we do have young professional families moving here. So we see some children with problems that are not yet diagnosed, and we have to get these children in the right track so they can go to Boston Children's or CHOP. But it all starts with making the right diagnosis. So this case was prepared with my current fellow. So symmetry in neuro is a blessing or is it a curse? The abnormality should just jump off the screen, right? And I showed you it's not always the case. So look, this is a 6-month-old boy, developmental delay, neurological changes of axial hypotonia, hypertonia of extremities, motor delay, poor weight gain, plateauing head circumference. Maybe because you guys are pediatric neurologists, you're gonna read this history and say, oh, I know what this is. But what I'm looking here are T1 weighted images of a 6-month-old and looks like a quite mature brain with no atrophy, but where is the myelin in the deep tracts? The brainstem, the posterior limb of the internal capsule, 6 months. Remember, this is 4 and 6. There's no myelination of the corpus callosum. So you may say this is delayed myelination. You have to repeat another scan after 6 months when the child is older than 1 year to complete your assessment and say this is definitely a hypomyelinating disorder. Or you can call your pediatric neurologist and say, no, it's just the first scan, but I'm really astonished by the lack of myelin here. And I think you could already start testing these genes. Look at the T2 and essentially it's the same thing. There's no myelination in the posterior limb. There's nothing. So could this be Pelizaeus-Merzbacher? Sure, it could be Pelizaeus-Merzbacher. But it is not, despite being the prototypical hypomyelinating disorder, it's not the only one. And there is a panel, a hypomyelination panel, and this was actually a tubulin mutation. You may know tubulin mutations. There are several. This is 2B4A. They are causes of asymmetric brainstem dysplasia. They're causes of polymicrogyria, callosal agenesis, fusion of the striatum, where the caudate and putamen look like a blob, and there's a bat wing appearance to the frontal horn. So there's several more characteristic appearance of tubulinopathies and tubulin-associated, microtubule-associated proteins. These all are involved in the radial glial cells and the migration of neurons from the ventricular zone to the cortical plate. But here is tubulinopathy causing no malformation and exclusively hypomyelination. So this was the confirmed diagnosis. So we sent this child to a neurometabolic reference place already with a diagnosis. So look at a normal 6-month-old, the deep white matter, including the callosum, is myelinated. The subcortical white matter is not yet myelinated on T1, and 6 months. So you already have the spleen. You remember 4, 6, 6, 8. So a normal 6-month-old has to have myelination of the posterior callosum on both T1 and T2. Notice the posterior limb, and here there's just no myelin at all. Again, normally myelinated callosum on T1, no myelination, monotonous isointense signal in this child with tubulinopathy. So these were the findings I described: the lack of age-appropriate myelin. This should be the posterior limb, the basal ganglia, corpus callosum. The impression is delayed myelination or hypomyelination disorder with the formal recommendation to repeat MRI after 6 months. But practically speaking, this is a hypomyelinating disorder, there was no doubt. This is, as I think I already mentioned, the varied presentations of tubulinopathies necessary for axonal development function. And also associated with other syndromes that have dystonia. So we can read more about tubulinopathies. Okay, this is our hospital on a autumn day, on a fall day. As you can see, the leaves changing colors. This is a dormitory. It's a beautiful building. The hospital is more modern. And this is part of the medical college and research building. And as you can see, we're very close to downtown. This is the Spire on Church Street, which is our major walking boulevard in Burlington, Vermont. Thank you so much for your attention. And I'll stop here and open the floor for our questions.
Thank you, Dr. Soares. Any questions?
I'll look at the chat as well, see if there's something there. I'm not being able to see the chat, so if there are questions there, Dr. Oki, please read it to me.
So there's a question from Dr. Gufaston. The question is diet used in the treatment of hypo or demyelinating disorders?
I don't think this question should be directed to a neuroradiologist, but I do not understand that diet would interfere with these disorders because you don't have accumulation of a toxic metabolite. I understand dietary restrictions are used mostly for the devastating neurometabolic disorders of the newborn, which are mostly amino or organic acidopathies and acidurias. Leucine encephalopathy, which is maple syrup urine disease, you have to restrict leucine and so on. But I don't think for hypomyelination, this has any effect. I think people have been trying stem cell therapies and so on to try to stimulate growth of myelin. If there's someone who's more experienced with the treatment of hypomyelinating disorders, please speak up. No more questions? Well, should we end our session?
Yes, Dr. Soares. Thank you so much for the lecture. It was really quite informative. I really enjoyed it. Thank you.
Thank you very much, everyone who logged in today. It was a pleasure, and I hope you all have a good weekend. Please feel free to email me if you have any questions related to the talk or otherwise. I'm always happy to chat.
Will do. Thank you.
Bye-bye.